Well, then, without further ado, we are delighted to introduce our fourth speaker. So this is Dr. Shannon Bates. Dr. Bates is an associate professor of medicine and directs the Division of Hematology and Thrombophilia, the discipline of Hematology and Laboratory Medicine, and the Adult Residency Program at McMaster. She played an integral role in the development of the thrombosis guidelines in pregnancy for the American College of Chest Physician guidelines, which we're all using with trepidation. She is a member of the Foundation for Women and Girls with Blood Disorders Medical Advisory Committee, and her clinical and research focus is on diagnostic strategies for venous thromboembolism in pregnancy. And she will talk about homozygous factor V Leiden with no thrombosis. Dr. Bates.
So thank you very much to the Foundation for inviting me into the audience for coming to a talk at 7 o'clock in the morning. So this slide presents my potential relevant conflicts of interest. And here's my case. So you are referred a 25-year-old woman who's 9 weeks into her first pregnancy for advice regarding the need for anticoagulant prophylaxis because she's had positive thrombophilia testing. And the testing was performed because there's a positive family history. Her mother developed deep vein thrombosis while taking oral contraceptives, and there's a paternal uncle who was diagnosed with pulmonary embolism. She herself has no personal history of deep vein thrombosis or pulmonary embolism. And unfortunately for her, it turns out that she's homozygous for the factor V Leiden mutation. So given this case and our topic, the objectives today are really to identify the indications for anticoagulant therapy in pregnant women with hereditary thrombophilia and with a prior history of venous thromboembolism. So here's our first question. Which of the following thrombophilias is associated with the highest risk of pregnancy-related venous thromboembolism? A, homozygous factor V Leiden, B, antithrombin deficiency, or C, protein C deficiency? So pretty even spread there amongst the two choices. Question 2. This patient's risk of pregnancy-related venous thromboembolism is approximately A, less than 5%, B, 10%, C, 25%, or D, more than 50%. Well, only one of those is right, so. Question 3, appropriate management of this patient's venous thromboembolic risk around the time of pregnancy would include A, antepartum aspirin, no postpartum prophylaxis, B, no antepartum prophylaxis, postpartum aspirin, C, no antepartum prophylaxis, postpartum low molecular weight heparin, or D, antepartum and postpartum low molecular weight heparin. All right. So thrombophilia, as you all know, is a laboratory condition that's associated with an increased risk of predominantly venous, but sometimes arterial thrombosis. And the frequency of thrombophilia really depends on the population being tested. However, if you perform testing in patients with a personal and family history of venous thromboembolism, up to 50% of those individuals will have evidence of some type of laboratory abnormality. Thrombophilias, as you know, may be hereditary, acquired, or mixed, and in this talk we're going to focus on the hereditary thrombophilias. So the hereditary thrombophilias can be really divided into two groups: the inhibitor deficiencies, or deficiencies of the natural anticoagulants, antithrombin, protein C, and protein S, or the gain-of-function thrombophilias, which are the factor V Leiden mutation that's associated with resistance to activated protein C, and the prothrombin gene mutation, in which there are elevated levels of prothrombin. The inhibitor deficiencies, as you can see on the slide, are quite rare, but are associated with a significant risk of venous thromboembolism. The most common form of the gain-of-function mutation, so heterozygosity for the factor V Leiden mutation or the prothrombin gene mutation, are more common, but are associated with a lower risk of venous thromboembolism. The homozygous forms are rare and have a similar risk of venous thrombosis over the course of a lifetime to that seen with patients who have deficiencies of the natural anticoagulants. So a number of adverse pregnancy experiences have been linked or putatively linked to thrombophilia, and these include venous thromboembolism and then the complications of pregnancy. So pregnancy loss, preeclampsia, placental abruption, and intrauterine growth restriction, and we'll work through all of those in turn. But let's start first with venous thromboembolism. So we know that the average annual risk of venous thromboembolism for non-pregnant women of childbearing age is approximately 1 per 10,000. The absolute risk of pregnancy-related venous thromboembolism remains controversial. However, if we take the best studies in which most, if not all, patients underwent appropriate diagnostic testing, it appears that venous thromboembolism complicates somewhere between 0.5 and 1.72 per 1,000 pregnancies. So that means that pregnancy is associated with at least a 5 to 10-fold increase in the risk of venous thromboembolism. Although these absolute numbers are low, it's important to remember that pulmonary embolism remains one of the leading causes of direct maternal mortality in developed countries. And surveillance data from the United Kingdom suggests that pulmonary embolism causes 1.56 deaths per 100,000 pregnancies. A number of studies have investigated the association between hereditary thrombophilia and first venous thromboembolism during pregnancy. This slide presents the results of a systematic review of 9 case control studies. So in the first column you have the thrombophilia, the second column is the odds ratio with 95% confidence intervals, and the third column is the estimated absolute risk of venous thromboembolism associated with particular thrombophilia. And as you can see, all of the thrombophilias were associated with a statistically significant increase in the risk of venous thrombosis. The highest risks, or the highest odds ratios, were seen in individuals who were homozygous for the factor V Leiden mutation or the prothrombin gene mutation with odds ratios of 34 and 26. The more common forms of those mutations, the heterozygous forms, had lower odds ratios of 8 and 6. Given the low absolute risk of venous thromboembolism during pregnancy, you can see that even for the thrombophilias with the highest risk odds ratios, the absolute risk was still quite low. Interestingly, in this systematic review, the deficiencies of antithrombin protein C and protein S had risks of venous thromboembolism much more closely linked or in the same ballpark as individuals who are heterozygous for the factor V Leiden or prothrombin gene mutation. Now, because of the design of those studies, they predominantly enrolled women who had no family history of venous thromboembolic disease. We know in the non-pregnant population that the presence of a positive family history increases the risk of venous thromboembolism 2 to 4-fold, regardless of the presence or absence of an underlying thrombophilia. So this slide presents the results of family cohort studies that examined the risk of pregnancy-related venous thrombosis in asymptomatic thrombophilic women with a positive family history. And again, you can see that the highest absolute risk of venous thromboembolism occurred in individuals who are homozygous for the factor V Leiden mutation. However, in this case, the absolute risk was about 4 times higher than what we saw in the previous slide, so approximately 14%. Interestingly, homozygosity for the prothrombin gene mutation was not associated with a similar risk increase, so only 3.7%. But it's important to note that the 95% confidence intervals are really quite wide, so you can't have a lot of confidence in this risk estimate. Heterozygosity for the factor V Leiden mutation and prothrombin gene mutation had absolute risks of venous thromboembolism of about 3%. And again, you see that antithrombin deficiency, protein C deficiency, and protein S deficiency had risks of about 3 to 5% as well. Well, how do we correlate this with our belief that antithrombin deficiency is really a high-risk thrombophilia during pregnancy? And in fact, we need to go back to those original studies that were performed in the 1980s and 1970s where they examined this question and take note of some important methodologic limitations. So these studies enrolled women who may already have had a history of venous thromboembolism, and at the time we didn't have readily available diagnostic testing. So patients were considered to have had deep vein thrombosis if they presented with leg swelling, because no one wanted to do venography on all of these patients, and pulmonary embolism if they had significant chest pain or shortness of breath. So there is a likelihood that we greatly overestimated the risk of venous thromboembolism during pregnancy with these thrombophilias based on the flaws of those initial important studies. So given this information, what do the guideline bodies recommend? And here I have on this slide the guideline recommendations from the American College of Chest Physicians, the ACCP, and the other very influential set of guidelines in this patient population from the American College of Obstetricians and Gynecologists, the ACOG. And the ACOG guidelines were published in 2011, and the ACCP guidelines came out in February of 2012. And although there are differences in the recommendations, the main take-home message when you look at these guidelines is that there is no recommendation for routine prophylaxis in all of these patients. So you have to do an individualized risk assessment. So this first slide is for women with no family history of venous thromboembolic disease. And what you can see is that the ACCP is quite stringent in its doling out of prophylaxis. So we only recommend postpartum prophylaxis in this group of women we consider to be extremely high risk, homozygosity for the factor V Leiden mutation and prothrombin gene mutation. And in fact, we don't think the risk is high enough otherwise to even recommend postpartum or antepartum prophylaxis with any of the other thrombophilias, including antithrombin deficiency when there's no family history. The ACOG considers antithrombin deficiency, homozygosity for the factor V Leiden mutation and prothrombin gene mutation, and heterozygosity or combined heterozygosity for the factor V Leiden and prothrombin gene mutation to be their high-risk thrombophilias, and they recommend antepartum and postpartum prophylaxis for those patients. If there is a family history, then the guidelines become more congruent. So then for both the ACCP and the ACOG, for women with asymptomatic thrombophilia, regardless of the thrombophilia, as long as there's a positive family history, both recommend postpartum prophylaxis. The difference is with the antepartum prophylaxis. So again, the high-risk group's different between the two guidelines. Well, what if you have a prior history of venous thromboembolism? So we know again that women who have had venous thrombosis are at increased risk of another clot during a subsequent pregnancy, but in the familiar refrain, the absolute risk remains controversial. We have 3 studies, 1 prospective and 2 retrospective. The prospective study, the ROCKET-P study, suggested that the risk of antepartum recurrence, if anticoagulants were withheld, was 2.4%. Although this study is methodologically strong, it's been criticized because of the small sample size, late gestational age and enrollment, and the fact that if we knew a woman had thrombophilia at the time of study assessment, they were not enrolled. So the retrospective studies were performed by Pabinger and DeStefano to get around those 2 limitations. They found a slightly higher risk of venous thromboembolism antepartum. However, it's important to note that those types of studies tend to overestimate risk because of the inherent methodology. The important message is that the risks that we find are pretty congruent. So the 95% confidence intervals overlap, and they're all less than 10%, which suggests that not every pregnant woman with prior venous thromboembolism needs anticoagulant prophylaxis antepartum. In the ROCKET-P study, there was a post hoc subgroup analysis in which they divided women into those with no thrombophilia and a prior transient risk factor to explain their previous clot, or those with thrombophilia and or an unprovoked event. And what they found is that the risk of thrombosis during a subsequent pregnancy was higher in that second group. However, that's a little bit different than what we see in the non-pregnant population, where thrombophilia is not an important predictor for the risk of recurrence. And in fact, when Pabinger and DeStefano looked at the role of thrombophilia in predicting the risk of recurrence, they did not find a positive association. So that means that the data is still controversial. Given this, in the most recent iteration of the ACCP guidelines, we've taken thrombophilia out of the stratification loop. So we actually don't have a recommendation for women with prior venous thromboembolism strictly on the basis of an underlying thrombophilia. The ACOG recommends antepartum and postpartum prophylaxis for these patients. What the guidelines do agree on is that all women with prior venous thromboembolism would benefit from postpartum prophylaxis, and that the one group in which antepartum prophylaxis can likely be safely withheld are in those whose previous clot was secondary to a transient risk factor that's not estrogen related. Otherwise, both of the guidelines provide a weak suggestion or weak recommendation for antepartum prophylaxis as well as postpartum prophylaxis. So let's flip now to the other pregnancy complications, and this slide is similar to the one that you saw previously. So on the first column you have the thrombophilia or the abnormality, and then you have the pooled odds ratios for early recurrent loss and late loss. And this data is from a systematic review of 25 case control studies that examined this association. And what you see is that there were positive or statistically significant associations for early recurrent loss and the factor V Leiden mutation and prothrombin gene mutation, and for late loss with those two thrombophilias as well as for protein S deficiency. For the factor V Leiden mutation and prothrombin gene mutation, the odds ratios are modest, suggesting a weak association. We all get kind of blown away by that odds ratio of 20 for protein S deficiency, but it's very important to remember that that odds ratio is based on a total of 15 women with protein S deficiency. So again, the 95% confidence intervals are pretty wide, and you need to take that with a grain of salt. With respect to the other pregnancy complications, of preeclampsia, abruption, and intrauterine growth restriction, you can see that there's a positive association with heterozygosity for the factor V Leiden mutation and the prothrombin gene mutation in preeclampsia and abruption, and there are no statistically significant associations for intrauterine growth restriction. However, again, we need to think about study methodology. So case control studies tend to overestimate the strength of association just by virtue of their methodology. Given that, Dr. Rogers and colleagues performed a meta-analysis of prospective cohort studies and examined the association between pregnancy loss, preeclampsia, abruption, and small for gestational age, and the presence of the factor V Leiden mutation and prothrombin gene mutation. And what they found is that with all of those examinations, the only one that had a statistically significant association was between the factor V Leiden mutation and pregnancy loss. But again, you see that the odds ratio is quite low, 1.52. And when we look at the absolute numbers, we see that if you don't carry the factor V Leiden mutation, you have an absolute risk of pregnancy loss of 3.2%. If you carry the factor V Leiden mutation, your absolute risk of loss is 4.2%. So we're looking at maybe a 1% difference there. So that tells us that really these thrombophilias are likely only part of a multifactorial picture when it comes to these pregnancy complications. There have been a few studies that have looked at interventions in women with thrombophilia and pregnancy complications. This slide presents the results of a randomized trial that was conducted in 160 women with either the factor V Leiden mutation, prothrombin gene mutation, or protein S deficiency, who had one pregnancy lost after 10 weeks gestation. And the women were randomized to either prophylactic dose enoxaparin or aspirin. And what you see is that there was a markedly better success rate in those women who received prophylactic low molecular weight heparin. And this study received a lot of play at the beginning. Over time, its importance has diminished somewhat, and it's diminished because no confirmatory studies have been published. So it's really hard to base management of a really large group of patients on a single study of 160 women. And the other thing that became much more evident over time is that really the low molecular weight heparin arm looks so good because the aspirin arm looks so bad. But in fact, the aspirin arm actually looks worse than probably if you had done nothing at all. So it's really hard to know what to make of this study, and at least for the American College of Chest Physicians over time, we've gradually reduced the importance that we place on this result. The other study that looked at thrombophilia and pregnancy loss was a subgroup of a trial called the ALIFE trial, and this was a randomized trial conducted out of the Netherlands, in which they took women with a history of recurrent pregnancy losses, no evidence of antiphospholipid antibody syndrome or hyperhomocystinemia or other etiologic cause, and randomized the patients to either placebo, aspirin, or aspirin and low molecular weight heparin. Women were not excluded from study participation if they had a hereditary thrombophilia, and they performed thrombophilic testing on the stored plasma later on. So in a pre-specified subgroup analysis of the patients who had hereditary thrombophilia, you can see that although the numbers are small, there's no clear evidence of benefit for intervention with aspirin or aspirin and low molecular weight heparin in the women with thrombophilia who participated in this study. So again, we don't really have good evidence for intervention in thrombophilic women with a history of pregnancy loss. The associations are not strong, and any supporting data is weak. So given this, let's look at the guidelines. So here there's good agreement between the ACCP and the American College of Obstetricians and Gynecologists. So both do not recommend screening for hereditary thrombophilia in the setting of recurrent early loss, and the ACCP certainly does not recommend treatment with antithrombotic therapy for prevention of recurrent loss in women with hereditary thrombophilia, or for that matter, in women with recurrent loss and no thrombophilia. With respect to the other pregnancy complications of abruption, intrauterine growth restriction, and preeclampsia, both the ACCP and ACOG make weak recommendations that there should not be screening for hereditary thrombophilia, and given that no appropriate trials have been conducted, neither recommends prophylaxis if you do happen to do the test and find an abnormal test result. So let's turn back to our questions and see if you learned something. So which of the following thrombophilias is associated with the highest risk of pregnancy-related venous thromboembolism? A, homozygosity for the factor V Leiden mutation, B, antithrombin deficiency, or C, protein C deficiency. So good job. Some of you still don't believe me, but that's okay. My feelings are only that hurt. Question 2. This patient's risk of pregnancy-related venous thromboembolism, so again, remember she's homozygous factor V Leiden, positive family history, is approximately less than 5%, approximately 10%, 25%, or more than 50%. Correct. So still a pretty big spread, but it's 10%. The 5% would be if there was no family history of venous thromboembolic disease. All right. Appropriate management of this patient's venous thromboembolism risk around the time of pregnancy would include A, antepartum aspirin, no postpartum prophylaxis. B, no antepartum prophylaxis, postpartum aspirin. C, no antepartum prophylaxis, postpartum low molecular weight heparin. Or D, antepartum and postpartum low molecular weight heparin. So the answer is D. So both of the guidelines agree that if you are homozygous for the factor V Leiden mutation and have a positive family history, you merit antepartum and postpartum prophylaxis. If there was no family history of venous thromboembolic disease, that would be where the guidelines might differ, where the ACCP would only recommend postpartum prophylaxis in that setting. So thank you very much, and I'd be happy to entertain questions. Yes. Hi.
Is there any evidence that it's safer to transition people off low molecular weight heparin to unfractionated heparin prior to delivery?
Yeah, so that's an issue that comes up quite a bit. And to be honest, there's various management strategies depending on which country you're in, I think. So in that, a life trial, if we talk prophylactic dose first, where a good proportion of women were receiving prophylactic low molecular weight heparin, they actually never stopped their prophylactic low molecular weight heparin, but they all tended to deliver at home in the Netherlands because they're tough. So there were no issues around the need for epidural, but there was no increased bleeding risk at all in that study. With respect to prophylactic low molecular weight heparin in countries where people might want to more routinely use epidurals, two strategies are used. Some people will stop the low molecular weight heparin 24 hours before a planned delivery. In other places, they'll transition to unfractionated heparin and then let the woman go to term and deliver on her own. And either strategy is perfectly acceptable. So I think more people on this panel probably use the second strategy where they transition to unfractionated heparin. In my center, the obstetricians love inducing people, I guess, so every woman on prophylactic dose low molecular weight heparin essentially has a planned delivery. With respect to therapeutic doses of low molecular weight heparin and unfractionated heparin, that's where it actually becomes really interesting because people transition to therapeutic doses of unfractionated heparin thinking it has a shorter half-life. It does not. So there was a really important study published back in the 1980s by Dr. Anderson and colleagues where they looked at, I think it was about 20 women who came in for delivery on twice daily unfractionated heparin because that's how we used to treat deep vein thrombosis and pulmonary embolism. And they looked at both the APTT and bleeding risk and correlated it with time since last injection. And what they found is that women could have elevated APTT levels for as long as 28 hours after their last dose of Q12 hourly unfractionated heparin. And that a reasonable proportion of these women actually had bad outcomes in terms of bleeding, even if you use protamine sulfate. So the issue for me has always been the half-life is less predictable with unfractionated heparin sub-Q than we might expect. And dosing of protamine sulfate with subcutaneous injections is a nightmare because there's a depot effect. So you have to use repeated dosing. Remember when I was a fellow, Jack Hirsch's first assignment for me was to develop a formula, but it involved calculus, so I just blew him off and never went and saw him again. So no, that question never got answered. And then the third thing is there have been rare reports of neonatal respiratory depression if the mom's given protamine close to term. So for all of those reasons, our practice is at my center is not to convert to sub-Q unfractionated heparin, but to leave them on low molecular weight heparin, and because they love doing planned deliveries, that's what we do. But I don't think you can say I don't need a planned delivery because I've transitioned to subcutaneous unfractionated heparin. I don't think you've solved the entire problem.
What's your recommendation for homozygous factor V for use of oral contraceptives?
Yeah, so that's an interesting one and a little bit off the topic here. Have a discussion with the patient. In general, there's a suggestion that these women should not use oral contraceptives, but again, it depends on the setting in which thrombophilia testing was performed, because I think we all know situations where women are sent for thrombophilia testing for God knows what reason, and there's no personal or family history of venous thrombosis. And I think you need to approach that a little bit differently than in a patient who has a history or a family history of venous thromboembolism. But that's probably the one group of patients, along with the deficiencies of the natural anticoagulants, where I would try and steer them to perhaps an alternative form of contraception. Yes?
Thromboprophylaxis in your patient.
Could you start at the beginning again?
Just about a question about the intensity of thromboprophylaxis, of the kind of regime, whether you would use a more intermediate in someone.
So good question. Again, no data. So you'll notice in the ACCP chapter, we gave the option of either prophylactic or intermediate dose. An intermediate dose is basically twice prophylactic dose. And the reason is because we could actually not come to an agreement about one or the other. So there haven't been great studies or great data at all looking at the risk of breakthrough with standard prophylactic dose low molecular weight heparin during pregnancy. There was a study recently published by the Dutch group that quoted a risk of recurrence of 5% in women receiving prophylactic dose low molecular weight heparin. The problem is that there was no actual measure of compliance in that study. And my feeling is 9 months is a really long time to inject. And that a lot of women who break through on prophylaxis are actually not taking their prophylaxis routinely. And it's perfectly understandable that they do that, because I cannot believe that pregnancy is a more thrombogenic state than, say, high-risk orthopedic surgery where standard prophylaxis works well. So you can see that I was for standard prophylaxis. Somebody else was for intermediate dose. Standard prophylaxis is my usual recommendation, unless the patient's at a high extreme of body weight, then I would go to intermediate dose. Yes?
Just a few words on anti-10A monitoring, when and when not.
Oh, that's a whole talk in and of itself. So anti-10A low molecular weight heparin monitoring, some people are very much for, some people are very much against. I'll just say the following points. One, the laboratory assays have important limitations, so they're expensive, they're not available everywhere, and there's important inter-assay variability. So you may not always get the same result if you test the same sample in different labs. Two, those anti-10A ranges that we work ourselves into a tizzy trying to get our patients into that right level, they're actually based on studies done in non-pregnant patients. And they're not therapeutic ranges, they're just where most of the patient's results happen to fall when you drew blood 4 hours after the morning injection, because it's for Q12 hourly dosing. The third thing is that there have been recent cohort studies where they've treated pregnant women for venous thromboembolism and either not monitored anti-10A levels or monitored them and not really acted on the results, and there wasn't a higher risk of recurrence than you would see in the non-pregnant population. And fourth, there really have been no good studies demonstrating high risk of recurrence with low levels and low risk and high risk of bleeding with high levels. So my practice, if I'm treating a patient for venous thromboembolism, I actually don't ever monitor low molecular weight heparin anti-10A levels, because I used to do it all the time when I first started, and I found out nobody actually needed an increased dose. The only patient population where I routinely monitor anti-10A low molecular weight heparin levels are in pregnant women with mechanical valves. And that's because there have been some studies that suggest that if you more aggressively titrate your low molecular weight heparin levels to these ranges, you may have a lower risk of recurrence, though not all cohort studies, or lower risk of valve thrombosis, though not all studies have actually shown that. And in some ways, it may just be treating me and making me feel better in a very scary situation.
For your case, just to clarify, the time of starting Lovenox?
Yeah.
Third trimester, or when you started?
Yeah, well, if you look at all of the data and pool it together, there's a risk of venous thromboembolism starting even early in the first trimester. So the risk does increase a little bit as pregnancy progresses, but even during the first trimester, there's a 20 to 25% risk of developing venous thrombosis. So my philosophy is if you're going to prophylax, start at the beginning. And I think we have one last one.
If you find thrombophilia in elderly women, I mean elderly 40-ish or something, who are still trying to conceive, do you do things differently? Do you tend to prophylax them? Because their chance for a successful pregnancy is shorter time.
So 40 isn't old, speaking personally. And I personally wouldn't do anything different, because again, there's no good evidence that the thrombophilia is playing a role in anything that's going on here. Yes. Sure. So I was just asked if I would just say a brief word about the new oral anticoagulants, the anti-10A inhibitors, apixaban and rivaroxaban, and the anti-2A inhibitor, dabigatran. The long and short of it is that, as we know, there's no data, but the other thing is all of the package inserts actually talk about reproductive toxicity in animal models, and although the amount that crosses the placenta varies from drug to drug, these drugs should really not be used during pregnancy or in breastfeeding. because there are important concerns about the risk to the fetus and to the breastfed infant, and we do have alternative anticoagulants. And given what the drug companies have put on their package insert, I may be speaking out of line, but given my experience, I think not. It's unlikely that these drugs will ever be tested in the pregnant population. So they'll never really be an option for us. All right, thank you very much.